Good evening, ladies and gentlemen. Our lesson for today is going to be on the pathology of brain tumors. I'm Dr. Robert Ramtran once again. Our objective for this lesson is going to be to list the presenting features of brain tumors, to gain knowledge about the diagnosis of common brain tumors, including the imaging features, and describe the treatment options for brain tumors. And finally, appreciate the natural history and prognosis of various brain tumors. So, brain tumors are a relatively rare disease in the population, affecting about 5 in 100,000, and the risk increases as we get older. We still don't have an exact cause, what causes brain tumors, whether it's going to be radiation from the environment, whether it's going to be diet, trauma, or other environmental factors. We do know that the incidence increases in age with a maximum age of between 65 and 74, as you can see here, by this very high peak at that age. Brain tumors can present with seizures, they can present with headaches, or worsening neurological deficit, which can be from just nerve palsies all the way to decrease in cognition or decrease in conscious level leading to comas. The tempo or the onset of symptoms and progression can give us a clue to the pathology. If we have a sudden onset of deterioration, we could assume that we've had a hemorrhage into the tumor. If the deterioration occurs over a few days, we can think of obstruction of the cerebrospinal fluid causing hydrocephalus or a very malignant tumor. Our deterioration within weeks to months suggests a high-grade tumor, and when our deterioration occurs over years, we're looking at a low-grade tumor or most likely a benign lesion. So after a good history and physical examination, imaging of course is the most important, and our most important imaging are CT scans of the brain and MRI scans of the brain, and of course tissue biopsy is needed for a final pathological confirmation. So these are common tumors we have here. This is a benign meningioma we can see here, which is always outside the brain tissue and extraaxial, arising from the arachnoid of the brain. And that's the finding on the MRI scan of the meningioma. They're very slow growing, so they can go to quite large sizes as we see here before they cause any symptoms. And that's how histology here, showing lobulated architecture called meningothelial whorls. I can see the whorls of the round uniform cells. And when you get to the pathology lab, you will get a chance to look at these under the microscope, and I would recommend that you get back to this lecture and just see what slides you can look at and identify these body cells. You can see the uniform nuclei with the psammoma bodies in it. Those are the psammoma bodies. Our next tumor is going to be vestibular schwannoma, also known as acoustic neuroma, arising from the Schwann cells in the 8th cranial nerve or the vestibulocochlear nerve. It presents with hearing loss, tinnitus, and sometimes ataxia. And that's our acoustic neuroma in the cerebral pontine angle. And you can see the 8th nerve as it extends into the internal auditory meatus here. And this is our histopathology of the schwannoma. Once again, I would ask you when you get into the anatomy, to the pathology lab, to take a look at the specimen. But it classically shows Antoni A tissue within the schwannoma. You can see these spindle-like nuclei, or what we call palisades of vericro bodies, which occupy this very dense cellular field. Our low-grade gliomas are infiltrative and very nondiscrete. You can see no margin here with that tumor. There's no enhancement, and it's very slow growing and could sometimes occur in young patients and usually asymptomatic for years. And a biopsy shows these astrocytes here, so just fibrillary neoplastic astrocytes, no necrosis, and a loose tumor matrix. So just increasing cells of astrocytes in normal field. High-grade glioma, more common in the elderly patient, a very aggressive tumor, short history, and the imaging looks very ugly. A lot of swelling and edema around the tumor, and that's what you can see here. So usually very cellular anaplastic atypical cells with increased mitotic activity and necrosis in the center of the cells. There's thickened vascular walls, as you can see here, and cell hyperplasia, making this pathognomonic for a high-grade glioma. And once again, we'll take a look at it in the pathology lab when we're in the lab. The most common tumors are metastatic tumor, and there may be one or many. They're usually discrete lesions, as we see here, with surrounding edema. And the patients usually have a history of prior malignancy to give us in. The histology is very variable, and it of course depends on where the primary lesion is, because a primary lesion from a breast lung cancer will obviously be different from a lung cancer, and histopathology resembles the primary lesion. So the treatment options for brain tumors, we obviously have none: steroids, surgery, radiation, radiosurgery, chemotherapy, or combination of all of these. And for no treatment, we usually would suggest that in our elderly patients with poor prognosis and highly aggressive lesions who have a poor life expectancy. And of course, we definitely have to take into patient and family wishes. And this is very important, where the team management comes into play and discussion with the family members. It's not a unilateral decision, but we do have to take the family into consideration. Of course, in small benign lesions which have no symptoms, we can always follow them with serial imaging to see if they get larger in size. Steroids can be used to buy us some time and decrease the vasogenic edema from it and alleviate some of the symptoms. It's rarely that they can be used to cure the symptoms, and it's not used for long-term management. Surgery can be done either in the form of biopsy, which just could be incisional, taking a piece of the tumor to test for histopathology to give us a histological working diagnosis for further management, or treatment of resection. Resection can be curative for benign lesions, or debulking in nature, which does cytoreduction, which increases the chance of other treatments such as chemotherapy or radiation working and help improve neurological problems. And that's a picture of course, doing surgery for a glioma, doing our craniotomy and mapping our tumor here and then removing the tumor. Radiotherapy is effective for primary and metastatic tumors and could actually double a patient's survival rate. Treatment is designed to maximize any damage and to minimize damage to tumor cells and minimize damage to normal cells around it. And here we have focused radiation, actually focusing on the tumor here and avoiding radiation to the surrounding brain from it. We have chemotherapy and other medical treatments which targets rapidly dividing cells, which would result in increased survival for the patients. We usually do it during radiation and after radiation, and it may increase the quality, but usually not the quantity of life. And of course, in the pipeline, we have safer operations, novel radiation therapy, and new chemotherapy drugs always being developed, a lot of supportive care, and of course, a lot of clinical drugs